Hi, this is Dr. Nick from the ECG Academy, and we're going to talk about rhythm analysis. In my years of practice reading ECGs, I find that diagnosing heart attacks and hypertrophy and all the common electrocardiographic diagnoses when you're looking at a 12 lead is pretty easy once you know what you're looking at. But you know what's challenging? The rhythm. I think figuring out the heart rhythm on a complex ECG is probably the hardest thing to do. And in the cardiograms that I see in the hospital that are misread, it's almost always the rhythm that's misread, not so much diagnosing an old inferior infarction or anything like that. The rhythm is really the hardest part. So we're going to start with rhythm analysis. And of course, the normal rhythm is known as normal sinus rhythm. And that's because the sinus node is what's responsible for initiating the normal heartbeat. So here's my little animation of a sinus rhythm. Recall that the sinus node fires. It activates the atrial myocardium, which spreads down and to the left. The impulse enters the AV node where it gets delayed for a split second, giving rise to the PR segment, and then the His-Purkinje system gets activated very rapidly, giving you the QRS complex. Again, the normal direction that the electrical signal takes is down and to the patient's left. And then, of course, you have repolarization, which gives rise to the T wave. So let's just get this out of the way. And the first thing you want to look at when you're reading an ECG is the rhythm. Now, I always tell people you really have to look at the forest first and then concentrate on the trees. So in this ECG, you have the advantage of a rhythm strip here with lead 2 that marches all the way across. And if you just kind of like scan it, you see that for the most part, it's fairly regular. It gets a little bit slower here, but we're going to talk about that in a later video. But most of the beats are fairly regular. And when you're analyzing rhythm analysis, especially when you're looking to confirm that it's a normal sinus rhythm, here are the things that you have to look for. You have to look at the P and the QRS and the T wave, make sure they're all related to each other properly. That involves measuring intervals like we did in the last section and making sure that everything falls within normal limits. You need to examine the P wave appearance because P waves have a certain look to them, and often if it doesn't look right, then it's not a sinus rhythm. The PR interval is very important, and we're going to get involved with that when we talk about AV block. But if you're going to call it a normal sinus rhythm, it should be a normal PR interval, which you should remember that the normal PR interval is 120 to 200 milliseconds, or 3 to 5 small boxes across. You want to confirm the proper rate and the electrical vector or the direction or the axis that the P wave is going, just to get a sense of where it's coming from. And I'll talk about that in a moment. And make sure that the P that you're calling the sinus P is the only one, because you'd be surprised how often you think that you see a P wave in front of every QRS, but there are other Ps hidden in other places. But we're going to get more into that when we do more complex arrhythmias. So anyway, with this tracing, you start to look at each individual beat, and you can kind of get a sense that there is a P wave that's fairly consistent in front of every QRS, but you say to yourself, well, what's the best lead to look at? I mean, if you look over here in AVL, you can barely see a P wave. Are we sure that that's a P wave even? Well, remember, all these lines are going simultaneously. So if there's a P wave here in AVF, then you can say with certainty that this, of course, is the P wave as well. Remember, with ECG recording systems, the limb leads are somewhat directional. Let's review that whole idea of vectors for just a second. Okay, so if we have the heart there, and here are the atria, and here we have the ventricles. We're going to look for normal vectors that are going down and to the left for the P wave, and of course for the QRS down and to the left as well. So which lead should we be monitoring? Well, if you recall our discussion on axis, lead 1 is from right arm to left arm. And which one is lead 2? Well, remember in English we read down and to the left. And that's going to be at a 60-degree angle above the horizontal, because we do have to cut this into 6 equal parts. So lead 2 here, look at that. It's looking down and to the left. So this turns out to be the optimal lead to look for sinus P waves is lead 2. So now let's go back to that other ECG, but let's take a close look at lead 2. Okay, this was the same ECG that I showed you before. Let me just go back to that. So this is here lead 2. We're going to be looking at a close-up of that. Okay, so in lead 2, you can clearly see that the beats are fairly regular. You can see the QRS complex right away because that's obviously the biggest signal. So look in front of it, and that's where you should be finding P waves. And then look after it, and that's where you should be finding T waves. So if we measure the PR interval here, it's 1, 2, 3.5 small boxes. So it's about 140 milliseconds, and that's normal. The QRS complex, this is just practice for you guys, is maybe 80 milliseconds. But you see this little jiggle here? Is that part of the QRS or isn't it? Well, here's where you need to look at the trees, the individual trees, because if you look at this QRS complex, there's a little jiggle, but it looks kind of different than this. And if you look at the first one, there's a little jiggle, but it looks, again, a little different. So you're better off examining several QRS complexes, maybe use your calipers. But I don't think this is really part of the signal here because it's obviously not there in these other two tracings. So I'd say the QRS complex probably ends here, and that would give it maybe 80 or 90 milliseconds there. And the QT interval, of course, we measure, and you can count the corrected QT as normal or abnormal. It looks normal because it's less than half the R to R interval, as we discussed in the previous section. But what about this P wave? Remember, if I had just looked at this P wave, I would say, well, what the heck is this little jiggle here? Is that the P wave? Well, you can see that that jiggle is absent in this beat and it's absent in this beat. So it's noise. It's high-frequency noise. The patient maybe moved around just for a fraction of a second. So you really kind of have to scan across and see what your favorite P wave is. Now, notice that this P wave is upright in lead 2. And so that means it is traveling down and to the left of the patient. And that's a good evidence that this is a sinus P. Then what's the rate? 300, 150, 100. And this would be 75, so it's kind of like 85 or so. So what do we have? We have a normal PQRST appearance. The PR interval is normal. The P wave appearance is normal. The rate is in the normal range. What is the normal range for normal sinus rhythm? It should be 60 to 100 beats per minute. Anything less than that, if it's less than 60, we'll call it sinus bradycardia. And if it's greater than 100, we'll call it sinus tachycardia. That's going to be in the chapter after this. We'll talk about those two specific arrhythmias. And it clearly looks like it's the only P wave. If you kind of look halfway in between, you see this T wave, but I don't think there's any suggestion that there's other P waves. So I think it's safe to say that this appears to be a normal sinus rhythm. If you go back to that original ECG, a lot of people will tell you, well, if you look at that circle of axis and you look at if this is lead 1 and this is lead AVF, anywhere in this quadrant should be where the normal P wave winds up. And so it should be positive in lead 1 because it's heading towards lead 1, and it should be positive in AVF. And lo and behold, if you look at lead 1, it's upright, and if you look at AVF, it's upright. So that confirms that this P wave is traveling down and to the left and is in this little quadrant here. Okay, that's just sort of like another way of establishing that the P wave is going in the normal direction. So therefore, it must be starting in the high right atrium and traveling down and to the left. We're at a normal rate. So pretty much this is a slam dunk. We can diagnose this rhythm as a normal sinus rhythm. Let's look at a couple of other examples. If you look at this ECG, you can see the P waves are upright in lead 1 and they're upright in AVF. Even though the QRS complex is a little bit different, it's also upright in lead 2, which again confirms that the P wave is down and to the right. What's the rate? If we count off, it's easier to find the rate if you look for a QRS complex that's on a heavy line. So let's do 300, 150, 175. It's just a little bit faster than that, probably 76, because you see this one falls a little bit on this side of the heavy line, and this one is even a little bit more on the side of the heavy line. So the heart rate's 75. The P wave is going in the correct direction. There's only one, so I would say that this is a normal sinus rhythm. It may throw you off if the QRS axis is abnormal, because if you look at lead 2, in this particular patient, the P wave is upright, but the QRS is inverted. So the P and the QRS do not always have to go in the same direction. The other thing I want to point out is that if you think about axis, and you look at the normal P wave axis being down and to the left, which is heading towards lead 2, well, where is AVL? AVL is up and to the left arm, exactly 90 degrees from lead 2. And so you'll often see that AVL to P wave will be really small. Well, what does that mean for those of you who work on telemetry units? The lead that you decide to monitor will affect how big the P wave appears. And if you happen to be monitoring AVL, you might not see any P waves at all. If you don't see P waves, don't assume that there aren't any, just change the lead. And sometimes you'll be surprised at how large the P wave appears in another lead. Okay, so let's get some more practice here. Now here's a patient. Now the first thing you see is, it looks a little bit funny. Of course, the biggest signal here is the QRS complex. Okay, so we can label QRS here, and we see that it looks pretty regular. But what's the rate? Now this QRS lands near a heavy line, so let's count backwards. 300, 150, 100. So it's closer to 150 than it is to 100. It's probably about 130 beats per minute. So this is at 130 beats per minute. It's a little fast. The other thing is, look, in lead 2, which we're monitoring, the PR interval is a little bit on the short side. Here it's 3 small boxes or 120 milliseconds. And it's also inverted. So the P wave is upside down. What does that tell us? It tells us that the P wave is traveling away from the feet, because if lead 2 is going down and to the left, this signal is going in the opposite direction. So this is clearly not a normal sinus rhythm. It's not even sinus tachycardia because the rate's 130, but the P waves are inverted. So this is actually an abnormal rhythm. It's a supraventricular tachycardia, specifically an atrial tachycardia, and we'll get into that in a later section. Okay, so you can clearly see this is not a normal sinus rhythm. Okay, one more time, we'll take a look at this. I'm only going to show you the limb leads because I want you to again recognize that if you're only looking at one lead like AVL, you might not actually notice much of a P wave. The QRSs are clearly very large, but the Ps are very small. And if you happen to be monitoring AVL, you may not even see the P waves, but clearly they're up right here in lead 2. Nice and large. The P waves are up in 1 in AVF, and that confirms that it's in the lower left-hand quadrant. And the rate here, we see this QRS lands on a heavy line. So we'll count 300, 150, 100, 75, 60. A little bit faster than that, I'd say 64 beats per minute. So this is a normal sinus rhythm as well. Okay, so now in the next chapter, we're going to talk about sinus bradycardia, sinus tachycardia, and how to recognize those. And we'll get some more practice in recognizing some of the different variations in the sinus rhythm. And so for the ECG Academy, this is Dr. Nick. Thanks for watching.